Right, hello everybody and welcome and thanks for joining us. I've got Nigel Jones with me today. Nigel, would you just like to introduce yourself?
Yeah, hi, I'm Nigel Jones. I'm Sales and Marketing Director at Practice Plan, and very good to be here.
So Practice Plan, how many clients do you have in the UK, roughly?
Well, actually, I probably should have been more accurate in my introduction because we're the Practice Plan group, which includes Practice Plan, DPAS, and Medenta.
Right,
And
okay.
across the two plan providers there, we've got something in the region of about 2,500 practices that we work with. And then an increasing number on the Medenta side with the patient finance that we offer.
Right. And do you mind me asking, obviously this COVID thing has kind of totally dislodged business in its normal sense. Have you had a lot of patients cancel their sort of arrangement, their practice plan with their particular,
Yeah,
I guess?
yeah. Dislodge is a great way of putting what's happening. My life, in common with many other people's, has been turned completely upside down, and I know just how much it's impacted on our practices that we work with. And when we started this whole lockdown in particular, and when practices had to close, obviously one of the first things we had to do was some scenario planning for what might happen. And at that point, we were anticipating quite a high number of cancellations. And it's been remarkable, actually. The reality has been very different to what we feared. And it's been very encouraging so far. So, I mean, we're looking at the moment of having, since this started in February, the number of patients on plans administered by us has gone down by less than 1.5%.
Wow, that's
Which
impressive.
is we were expecting something quite more dramatic than that. I should say that, and the main reason for that is actually because there are not patients joining. There's always a natural turnover of patients coming on and off of plans. So you get people cancelling for reasons to do with moving home, changing job, change of personal circumstances. And some of that has carried on, obviously, but
Yeah.
normally you replenish that with new joiners. But with no patients going into practices, you haven't had the new joiners onto plans. But yeah, very pleased with that.
Very stable. I mean, arguably, it might be the calm before the storm. So when they come back, they sort of start looking at their arrangements at their dental.
And that's a very important point that we're not blind to, because clearly we're going to enter some economic turbulence, or maelstrom, I think you may have referred to it in the past. And what that means in terms of the number of redundancies. Okay, everyone's on furlough at the moment, so there is a slight suspension of reality. But
Yeah.
but even then, when I look back to what happened in 2008, 2009, in the wake of the financial crash, as Lang & Buisson put it in their reports, actually plan-based practices were largely insulated from the worst of that. So you're right, we're definitely not out of the woods yet, but grounds for optimism at the moment.
Yeah, I think you're right. I think the general sort of received wisdom is that in times like these, people prioritize health, and particularly when we can see, the stress of the NHS, and if you were not a private dental patient and you were on the NHS, your waiting times are going to be quite far out now. So I think people tend to prioritize health. And so in one sense, it's secure. I can understand that. But there's a more complex challenge ahead for you, I would imagine, because the cost base of dental practices is going to change quite a bit. It's not just the cost of the PPE, as we're probably exhausted reading about, but it's more importantly, I think, is the downtime in a practice because of the new patient management systems. And I've been talking to, you can imagine, I've been talking to a lot of people about this, because that's the profitability is going to be the big question, because traditionally dental practices, although everybody thinks they're very profitable, they're not really. And that's principally because, dentists are extremely well paid. So, there's it's a sort of false situation. So they exist in a different zone, perhaps, to the rest of us because of because of the nature of how they're rewarded. Things are going to change because the throughput of production is going to slow down. Some people are talking about losing 90 minutes per day per surgery. And you know, that just plays massive havoc with your production, your profit, ultimately your profitability. Patient plans exist and provide the practice with a lovely check every month of 10 grand or 15 grand or whatever, and they kind of get hooked into that, the practices. But I think there's always been some question around profitability of the plans themselves, particularly when you look at the profitability of hygiene. So I suppose my main concern, as I advise my clients, is can you really, how can you possibly continue to provide hygiene twice a year and 2 exams twice a year for, £18 a month or whatever it might be? How's that going to work?
Yeah, I mean, it's a good question. I think this point about just how much change we're going to see as we emerge from COVID, there'll be the transition to, and I'm slightly bored with the phrase, but I'll use it anyway because I can't think of a better one. But as we emerge into the new normal, there's that transition phase and then that stable phase. And it's not completely clear to me at the moment exactly what that looks like. Even today, I think there's been further information provided by the CDO for England, and sort of trying to process all that information to see what the practical implications will be is quite tricky. Like you, I've heard of stories of a downtime between patients when there have been aerosol generation procedures of an hour that could be mitigated to half an hour or 20 minutes or 15 minutes, depending on air filtration systems, ventilation systems, all of that. So it still seems to be quite a moving feast at the moment to try and wrap your head around. That broader question about plans. I mean, one of the really important things that I think is sometimes misunderstood is that what a dentist puts into a plan and what they charge for that plan is entirely within their gift. So it's not something that's dictated to or prescribed. We on the point about the plans, and I don't particularly recommend this because I think it can get quite confusing from particularly a front desk point of view. But just to illustrate the flexibility point, we have one practice that's identified 14 different groups of patients within their base and has got 14 different types of plan configured to suit the requirements of those particular patients. Yeah, so you grimace. And I think you're right that it adds lots of complexity, but it shows they've got quite a bit of flexibility themselves in terms of how they configure the plans to reflect the new world. And I think we've got one practice, for example, that I'm talking to at the moment, and they've decided they're going to take this opportunity to turn their practice into a pretty exclusive boutique practice. And they're looking at running cash flow models based upon 5, 6, 7 patients a day per dentist. Now that's a very different way of approaching it, but they feel comfortable with the work they've done with their dental accountant, that actually it's doable, provided they can find the 5, 6 or 7 patients prepared to pay the fees that they will then have to charge. But given their starting point and their base of private patients, they feel reasonably confident that that's going to be the right way of doing it. Now, I use that again to illustrate, I think different business models are going to emerge in different ways. I've seen a really interesting article, I think, by your colleague Ross, around the way that cash flow for practices will be impacted depending on different approaches. And things like the shift system. We're seeing a lot of practices talking about having team A, team B, and being able to meet the requirements of what they offer under the plan through much more extended hours. But that does take some thought and does take some preparation. Now, the relevance of all of that to plans is, do you completely change your approach to plans and end up with a different type of plan to reflect a very different business model? Or do you find ways of adding value to your existing plan to justify the current fee or an enhanced fee that you may end up feeling you have to charge? Most of the practices we're talking to seem to be going down the route of finding ways of adding value. And that in part, I think, is going to involve teledentistry and supplementing face-to-face consultations with virtual consultations. I also think...
Can I just drill down a little bit more on this sort of hygiene area?
Yeah.
So there's a school of thought at the minute that, generally speaking, if you accept production times are going up, and if you accept there's an additional cost for PPE, then there's there's a sort of notion that the cost of services to the patient need to go up by about 15%, just across the board. But it's more critical in the hygiene area because of the aerosol, as you can imagine. So the clean down time, etc., is longer. And so there's a strong movement that says that hygiene appointments should be an hour, not 20 minutes or half an hour, and that we should be charging 120 or 150 pounds per session. So it's sort of like that at that sort of rate, it makes money, but it sort of changes the whole kind of perception of hygiene. Maybe I don't know what you think about that.
Well, I definitely think there's a challenge when it comes to thinking about what hygiene appointments look like in the new world. I think it's really important, it says he is a non-clinician, just to remember that there's more to a hygiene appointment than just the clinical intervention, what goes on in the mouth. So all of the oral hygiene instruction, dietary advice, the measurement of progress since the previous appointments, the general motivation and education points still apply. And when it comes to the clinical bit, many practices are talking about temporarily, until everything becomes clear, going back to hand scaling. So there's a risk that hand scalers could become the new toilet rolls, where we have a complete run on them. So certainly a number of people are feeling like they can adapt. And if there's one thing that I've learned about the dental profession over the 30 odd years that I've been working with it, is that it's pretty adaptable. It is able to adjust to reflect changing circumstances. And there's been a number of occasions in that 30 years when things looked like they would have to completely change. And actually, yes, there was change, but they found a way of mitigating that to a degree. So I think that's going to be an interesting thing to see how people adapt. But certainly, I think there will be scope, for example, the practice I was mentioning earlier on, for people deciding that's what they want to do with hygiene appointments, that's what they want to charge, and that they will build into the price of their plan. And I think then the real challenge is, have you got enough patients who are willing to pay those enhanced levels of fees? And that's clearly going to vary from practice to practice and circumstance to
location and lots of things. But I suppose what I was trying to get to is, in my mind, is a headline price. So instead of being, for example, £18 a month, maybe it's £30 a month, but it's an enhanced service. I just wondered if there's a sort of breaking point with the public, in your view, about, I'm quite happy to pay 15 quid a month for, a sort of a loose dental arrangement that gets me a couple of checkups and a hygiene appointment, or a couple of hygiene appointments. Paying £30, it's it's more serious amount of money and more considered the purchase. And, if that was the case, would you anticipate volumes of plans would decrease?
Well, it's again another good question. I mean, I think my experience has told me that actually we've got to be slightly careful about the pricing point when it comes to patients, because I've worked with a number of practices. In fact, I can think of one example of two practices that went private at the same time on the same street in a town in Essex. One charged twice as much as the other for their plan and recruited twice as many patients to the plan. Mm. A lot of it was to do with the confidence and their belief in the value that they were providing patients. Yeah. And going back to your very first question, which was around the cancellation rates, I think one of the reasons why plans are so robust is because the people that choose plans have a loyalty to their dentist that actually overrides quite a lot of normal consumer considerations. And I think there's a really interesting thing that I've never been able to properly delve into and explore about how patients select a dentist for their routine, ongoing general dentistry, where they attend for what's essentially a health screening voluntarily and turn up quite often not knowing if there's an issue at all and hoping that there isn't one. But the person that could be about to tell them, they have to trust implicitly. Trust is so important. And I think one of the things that is definitely a feature is that once you've found a dentist that you trust to deliver news that you might not want to hear and that you accept it, you can be very, very reluctant to give that particular dentist up. So in terms of the pricing point, a lot will depend on the level of loyalty that you've got with your patients, the amount of trust, and how much you can test that. If you've only been seeing those patients for a short period of time, then I think it's going to be a challenge to increase your fee significantly. Not impossible, but a challenge. If you have been seeing your patients for a long period of time, you may find that actually the reverse happens, in that knowing that you're reducing the number of patients that you can see, that actually creates a greater demand. And you could even imagine waiting lists, as we saw happen in the wake of the 2006 new contract. One of the other things I think is a dynamic that I haven't properly got to grips with yet is actually what all of this means for the longer term future of the NHS. So many of the challenges that you're putting forward quite rightly to me at the moment as to the financial dynamics of a practice, I'm not clear how that's going to work in an NHS setting with an NHS contract that has to offer value for money for the taxpayer. And it's been fascinating listening to various people, looking at what's happening in Wales, looking at what's happening in Scotland. There was a really interesting interview with the clinical director for Scotland, who happens to be a dentist, although he represents the wider group, talking about there will be a need to look at different funding models for the NHS. There will not be any extra money for dentistry. We may need to target it more effectively. So the reason for talking about that is that it's not impossible, and I appreciate that I will potentially want to view it this way, so, you know, rose-tinted spectacles and all that, but there is a very real possibility that the NHS comes under pressure, and that actually drives people into the private sector or pushes out waiting times for NHS dentistry, that makes the demand for private dentistry greater rather than less. You've got to balance that out with the economic situation. It was clear from the 2008 financial crash, the value of private dentistry in the UK dropped by about a third, something like that. So you can't ignore that economic pressure. But I first started working with practices in 1990, when we were in the midst of a recession then, and a new NHS dental contract was introduced in October of that year. And actually private dentistry grew quite significantly because the loyalty to individual dentists overrode the economic considerations for some people. Now, it's really hard to generalize. Different people in different circumstances, different levels of job security, but you get the gist of that.
Absolutely. But I think I would say that dentistry has become more promiscuous in terms of patients do move around a bit, particularly for high value treatments.
I would just say I completely agree with that latter point. So I think there's a way that they choose a dentist for their ongoing routine care, and then they definitely behave in a far more consumer orientated way for the high value treatments, particularly cosmetic treatments. I completely agree with that.
Nigel, do you see the sort of potential for a kind of more comprehensive plan, you know, where all treatment up to a certain type, or, you know, some sort of, you know, I know they used to do it in the old days, but and it's now become unfashionable. But is there a potential return to that sort of total treatment type plan where you pay £50 a month or £40 a month, and this is whatever happens, you know, you're covered? Doesn't include implants and doesn't include elective orthodontic treatment or something, but everything else is covered by this plan. Do you see a potential for that?
It's not impossible. As you may or may not be aware, I started my career with Denplan, and the only plan that was available at that time was the full care capitation plans, as they were called. And I totally bought into that concept. What Steve Noor had set out to achieve in terms of aligning the incentives of the dentist with the incentives of the patients, I think was absolutely right and admirable. There was a practical reality that intruded on that. And I think well, there's two practical realities. One is about the nature of the relationship between the patient and the dentist. If the dentist is taking a long-term view of the relationship or medium-term view of the relationship with the patient, I think there's very much a case for a full care type approach. It needs some management. You need to make sure you've got people in the right categories. You need to review that on a regular basis. You need to stay on top of exactly how much time you're spending so that you don't fall into the trap of inadvertently losing money on it. But with the appropriate amount of management, it can be done. There is another challenge, though, which I think is to do with the concepts of general dentistry and how much more specialist work coming. So when I started my career helping dentists introduce plans, endodontics was automatically included as part of that plan. But over the years, it's become increasingly specialist and therefore harder to build into an all-embracing plan. So I think that's the other sort of thing that needs some thought, because there will be, as techniques get more and more refined and therefore incur more cost, how you can wrap that into a normal plan type scenario gets more and more problematical. And clearly with maintenance style plans, you've got a lot more flexibility.
Mm. Well, listen, Nigel, it's been really good to hear your views. Can I, just before we finish, I just ask you how you're supporting your 2,000 clients in the UK? You know, some of them will be, hopefully most of them, in the private and mixed practices will be opening up next week in defiance of well, let's not get into the politics of it. I think we probably both agree they haven't been treated very well by the professional bodies. So as they open up, as they start to open up, what's your advice? What are you doing to sort of help them? How will you engage with them?
Well, you'd expect me to say this, but I'm really proud of what we've done to help practices. We managed to get a set of online resources up very, very quickly into this crisis. By March 23rd, we had people able to access those resources, and we've been updating it twice daily ever since. Program of webinars giving people access to all kinds of advice, financial, HR, mental health, all of that kind of thing. And increasingly important within that has been sharing of best practice. And they're so creative, a lot of our clients, that the different ways that they've come up with communicating with patients, supporting patients. You know, we've had people, some of our clients delivering shopping to shielded patients. It's amazing, that sense of the practice as part of the community. And the more we can circulate these good ideas and these suggestions, then the better. And that's obviously what we'll carry on doing as people open up. We've been very, very careful to make sure we update that site so that as the new information comes out, and it changes very, very frequently, as you know, that they've got access to it immediately. And I'm really, really proud actually of the fact that increasingly a number of practices are saying that they're using our site as a default site, along with 2 or 3 others. The BDA site, I think, has also been pretty good in the main. So that's been good, and we'll continue to do that and continue to enhance that. You may be aware that we, during April and May, we effectively rebated 50% of our admin fees to practices. And that was very purposefully done because we recognized that the cash flow issues were likely to be at their most acute in those couple of months. And that was our way of financially supporting practices. And they've used that money in a variety of ways to invest in PPE. We've got practices buying new shields for their reception areas, a variety of things that they're doing. And I'm really, really, again, proud of that very practical support. But things are changing. I can change my view on what's going to be required during the course of a 2-hour meeting because a new piece of information comes in.
Yeah,
So I think what's critical for us is that we remain on our toes with this, getting information out to people as quickly and easily as we can. And I have a weekly meeting with my team where we talk about the latest developments and agree an update of the action plan on precisely how we can support practices, because they are going to need it, and they are going to have to rethink how they approach things. They are going to need to do some planning and some preparation. They are going to need to access specialist support from organisations like yours. They need to think quite carefully about this, because I don't believe that they can just hope they can open their doors and things will get back to normal very, very quickly. I think there'll be some lasting changes, and they need to be prepared for that and thinking about it carefully. So we'll be there to do our best to support them through that.
Nigel, thank you very much. I appreciate the time, and maybe we can chat again soon, maybe in a couple of months' time, if we do a sort of post-launch analysis and we can compare notes maybe.
That would be excellent. I'd really, really enjoy that, Jonathan. Thank you.
Nigel, take care. Thank you.
Cheers.
Yeah.
Bye.